Yes, now you can start.
Thank you, sir. Good evening, everyone. On behalf of Indian Society of Anesthesiologists, I extend a very warm welcome to all the dignitaries, respected faculty members, and dear postgraduate students who have joined us today for today's ISA National PG class. As a part of ISA National Academic Initiative, this National PG classes are conducted every Monday evening at 6:30 p.m., providing a consistent platform for learning, discussion, and academic growth. Today, too, we have very important topics. Number one, oncoanesthesia, navigating complex perioperative challenges. Number two, mastering lung isolation. We shall now begin the sessions with seeking the blessings of Goddess Saraswati. As we have now invoked the blessings, we shall now proceed. Hello, I'm Dr. Subha Lipsha, currently an Oncoanaesthesia Fellow at Tata Memorial Hospital, Mumbai, and it's my great privilege to serve as a screen coordinator for today's ISA National PG class. I again welcome you all once again for this academic initiative. May I now invite our Honorable Secretary, Dr. Rajiv Gupta, sir, to address the gathering and share a few words.
Thank you, Dr. Subha Lipsha. I welcome you all to this ISA National PG online class. Welcome to Department of Kidway Memorial Institute of Oncology, which is from Mangaluru. And under the great mentorship of Dr. Aarti and Dr. Henjirappa, we are taking this class on oncoanesthesia and navigating complex perioperative changes and lung isolation. So this is very important, very good topic, and complex also. How to go for lung isolation, what are the devices used for that, which is one is good, DLT or bronchial blocker. So we have to learn each and everything, and which is very important for the PGs. So because there are so many physiological changes that takes place during one lung ventilation, what strategies to be adopted during this phase, and how to manage hypoxemia or something like that. So let's start and begin with the class.
Thank you for this wonderful words. I would like to now hand over to my co-screen coordinator as she will introduce our esteemed faculty.
Thank you, Dr. Subha Lipsha. A very good evening to everyone. Myself, Dr. Sagarika Bora, currently working as Registrar at the Department of Anesthesiology at Guwahati Medical College. It's indeed an honor to serve as one of the screen coordinators for today's session. It's my pleasure to introduce the esteemed faculty members who will be moderating today's presentation. We have with us Dr. Aarti B.H. Ma'am, Professor and Head of the Department of Anesthesiology and Pain Relief, Kidwai Memorial Institute of Oncology, Bangalore. Ma'am has PG teaching experience of 25 years. She has specialty interest in difficult airway, thoracic anesthesia, oncoanesthesia, oncocritical care. Ma'am has various achievements to her credit. She is scientific chairperson for ISACON Karnataka 2026, She's been past President ISA Bangalore Metro Branch, past Vice President ISA Bangalore Metro Branch, postgraduate examiner and DNB assessor. Ma'am has received Certificate of Commendation by Rajiv Gandhi University of Health Science. Ma'am has more than 25 national and international publications. The next faculty that we have, Dr. Henjarappa K. Sir, Associate Professor, Department of Anesthesiology and Pain Relief, Kidwai Memorial Institute of Oncology, Bangalore. Sir has PG teaching experience of 19 years. He has specialty interest in difficult airway, oncoanesthesia, oncocritical care, cardiac anesthesia. He is Honorary Secretary ISA Karnataka State Branch. He's been BBRON Medical Trust Scholar, Postgraduate Examiner, NMC Assessor PG. He's been past Member Secretary ISRB and MEC, Kidwai Memorial Institute of Oncology. Sir has received BBRON Trust Scholar Award. He has 20 national and international publications. Welcome, ma'am. Welcome, sir. Now, before we go ahead with the class, I would like to explain certain rules to the audience. You all will be muted throughout the presentation. Please keep your videos off during this session. If you have any queries, you can type in the chat box. All your queries will be answered at the end of this session. Now, I would like to request today's faculty moderator to kindly take over and introduce the postgraduate presenters for today's presentation.
Thank you, Sagarika. At the outset, I extend warm greetings from Kidwai Cancer Institute. We are very proud to say our institute is ranked as number 5th position from past few years in all over the country. And I thank ISA National for giving me this opportunity to host this prestigious ISA National PG classes today. Today, here to coordinate or moderate the sessions, myself, Dr. Arti Sagarika already introduced, and Dr. Henjarappa. We have two postgraduates, final year postgraduate students, Dr. Nazreen Nisha, who's going to coordinate I'm going to moderate her class, and Dr. Rakshita with Dr. Henjarappa. So now we are going to start the first discussion on demystified or challenges, what we come across in oncoanesthesia in general, a comprehensive approach by Dr. Henjarappa and Dr. Rakshita. Over to you, Dr. Henjarappa and Rakshita.
Thank you, madam, for that kind introduction. With the oncoanesthesia is emerging as a field, as a super specialty or a subspecialty by itself. Let us look at what are the inherent problems or challenges and what we can do for having a better outcomes. Rakshita, do you think that is there any need for having oncoanesthesia in the present system of healthcare?
Yes, sir. Because India is facing a rising cancer burden, around 15 lakh plus new cancer cases are annually reported, and it ranks globally third after China and the United States, sir.
Yeah, if such is the huge burden of cancer globally and especially in India, does the oncoanesthesia needs to be considered as a subspecialty by itself, or it's just we can go ahead as a comprehensive approach of a general anesthesia? How does you think that oncoanesthesia is a very much different, or it needs some specializations apart from the routine anesthetic care?
Yes, sir. Oncoanesthesia has to be considered a separate subspecialty because it is not just routine anesthesia for cancer patients. It is subspecialized long-term care dealing with altered physiology from diagnosis to the survivorship or palliation. Whereas in routine surgeries, the patient will come for one procedure. So our care ends at immediate post-operative period. But whereas in cancer patients, from the diagnosis, then for the therapies, chemotherapy, radiation therapy, then for surgeries, again follow-up surgeries, and again for palliation care, we will be taking care of the patient. So it is a cancer journey. And cancer, it's not just a local lesion, it affects the other organ systems also. In routine patients, all the aspects will be normal, patient will be healthy. Whereas the patients we see, if the patient will be cachetic, sarcopenic, immunosuppressed, patient will be having anemia, thrombocytopenia, and they'll be having hypercoagulable risk. And because of chemotherapy and radiation therapy, they'll be having chemotherapy-induced cardiomyopathy or radiation-induced fibrosis. And in routine anesthesia, we won't worry about the long-term outcomes of anesthetic agents. But whereas in oncoanesthesia, the concerns are there, the effects of anesthetic agents on tumor recurrence, metastasis, and immune surveillance, mainly the natural killer cell functions. And how oncosurgery is different from routine surgeries. The oncologic surgeries are longer in duration, more invasive, has higher blood loss, major fluid shifts, and involves multidisciplinary teams. These are the examples of oncosurgeries: cytoreductive surgery with HIPEC, hyperthermic intraperitoneal chemotherapy, radical head and neck surgeries, esophagectomy, pneumonectomy, pelvic exentration, and limb salvage surgeries. This is one such example of a scenario where this patient has a huge tumor. So it will be longer in duration, it will be more invasive, and has higher risk of blood loss and fluid shifts, and involves the multidisciplinary team. And coming to pain management, in routine anesthesia, we will manage the post-operative pain till discharge. Whereas in oncoanesthesia, along with the acute pain, the chronic cancer pain and the neuropathic pain, we have to manage, and integration with palliative care is necessary. And coming to ethical and communication challenges, since most of the cases will be high risk procedures with poor prognosis, the oncoanesthetist has to explain all these consents and the DNR discussions. So the emotional intelligence with ethical clarity is important. And REOT, this is unique to oncoanesthesia, that is written to intended oncological treatment. So after the surgery, patient has to resume their planned adjuvant therapy. And why it matters for oncoanesthesia? Because patients has to, after surgery, they have to go for chemotherapy, radiation therapy. If there is any delay, it may affect their survival.
So, with so much of specialty oncoanesthesia involving, be it the duration of the nature of the surgeries, be it the endpoints, what you are looking at, because the patients need to go for some other form of therapies after completing the surgical treatment, the kind of patients or the systemic illnesses, what they have, the effect of chemotherapy or the radiotherapy or the surgical process when they come up for repetitive surgeries. All these things make the oncoanesthesia as a true subspecialty when compared to routine anesthesia practice. And we need to keep all this in our mind. And if such is the scenario with oncoanesthesia, can you just tell me what are the common preoperative challenges that an anesthesiologist will face in anesthetizing routine cancer cases?
Yes, sir. And because of the cancer and its effects, and because of the treatments like chemotherapy, radiation therapy, targeted therapy, and immunotherapy, these also cause systemic organ dysfunction, which has to be evaluated carefully and preoperatively. All these effects can complicate the physiology, influence the drug choice, dosing, and the perioperative risks. And this is one such example. Young patient who was apparently healthy before, and after she underwent chemotherapy, the 2D echogram we did, and that LV global hypokinesia and reduced global function, LV global function was noted. So this is one classical example of chemotherapy-induced cardiotoxicity. And the most common group of drug is anthracycline, doxorubicin, epirubicin, daunorubicin, which can manifest as decline in the left ventricular ejection fraction. And these are the other drugs which is having manifestations of cardiotoxicity. And coming to pulmonary complications, the most important drug category is anti-tumor antibiotic bleomycin, which can manifest as acutely. Patient may be asymptomatic. There will be only deterioration of pulmonary function test and DLCO. Whereas chronically, patient might develop progressive interstitial fibrosis, hypersensitivity pneumonitis, and diffuse alveolar damage. And these are the other chemotherapy drugs which affects the respiratory system. And other chemotherapy drugs which can affect other systemic effects, renal, hepatic toxicity, and CNS toxicity. And along with chemotherapy, even radiotherapy also will have effects on each system. In head and neck, it causes changes in the airway. It can cause peripheral neuropathy. In respiratory system, it causes radiation-induced pneumonitis. In cardiovascular system, arrhythmias, conduction abnormalities, myocardial ischemia. And in renal nephropathy and generalized reaction like desquamation, hyperpigmentation, and acute mucositis. And because of the cancer itself and because of the radiation therapy, there will be difficult airway and anatomical distortion. These are such examples. Here you can see there is huge tumor where airway assessment is only difficult, and here the examination or it is obscuring the oropharynx, and here the mass is protruding outside, which can result in difficult mask ventilation and difficult laryngoscopy. And local effects of mediastinal mass. In this X-ray, you can see the mediastinal mass, which is so huge and in near the trachea and bronchi, can cause compression during the compression of the trachea and bronchi during the induction of anesthesia or positioning. And assessment and optimization of physiological reserve is very important in cancer patients because they often have a poor nutritional status. Because of their catabolic state, the patient will be cachetic and they'll be having hypoalbuminemia, which can affect the healing and pharmacokinetics. And patients will be deconditioned, loss of muscle strength, and low exercise tolerance, which can increase the perioperative morbidity. And timing of surgery related to cancer therapies is important. Because of chemotherapy and radiation therapy, there might be acute toxicities like myelosuppression and coagulopathy. So we have to ensure the time interval between the therapies and the surgery to ensure better recovery. Increase the risk of infection and coagulopathy. Because of bone marrow suppression, patient will be neutropenic, which increases susceptibility to infections. And thrombocytopenia and coagulations from disease itself or therapies can affect our regional anesthesia decisions and increase the bleeding risk. Drug interactions and anesthetic implications. The cancer therapies will have interactions with anesthetic drugs and may alter immune responses. So the choice of anesthesia technique, regional versus general, volatile versus propofol, will affect the perioperative outcomes. Because of chemotherapy and radiation therapy, the central line and peripheral access will be challenging. Skilled planning of lines and catheters is needed. Psychological and social challenges. The diagnosis of cancer itself will be traumatic to the patient. So the patient will be having fear of repeated procedures, investigations, therapies, and surgeries. So they'll be having high anxiety, depression, fear of mortality and pain. So which can influence the cooperation and consent. So effective patient education and psychological support is an important component of preoperative preparation. So all these are the major preoperative challenges in the oncoanesthesia.
With so much of challenges, be it be because of the disease per se or because of the treatment modalities, and cancer itself being a systemic disease, many of the organ systems are affected and they'll not be in an optimized state. So, but because these surgeries are, you cannot keep on postponing or taking a long time to optimize. At one end, you need to optimize the patient's condition. Other end, you need to time the surgeries. Okay, keeping this in mind, how can we improve or optimize the patients for cancer surgeries?
Yes, sir. Prehabilitation is important. So what is prehabilitation? It is the process of preparing a patient physically, nutritionally, and psychologically before surgery to improve the functional capacity and enhancing recovery and reduce post-operative complication. These are the objectives of rehabilitation: to increase functional reserve before surgery, to reduce surgical stress response, to improve cardiopulmonary fitness, enhance nutrition and immune function, reduce anxiety and improve mental resilience, shorten the hospital stay and reduce the complication. So what are the measures we undertake? Exercise therapy, aerobic exercise like walking and cycling if patient is fit, resistance training and strength work, respiratory muscle training, and incentive spirometry, especially in thoracic surgeries and upper abdominal surgeries. All these exercise therapies are tailored based on patient's baseline fitness. And nutritional optimization, assessment of nutritional status, weight, albumin, and protein intake is important. Diet plans to reduce malnutrition and muscle wasting. Improved nutrition will support the wound healing and immunity of the patient. This is the malnutritional universal screening tool, MUST, which is based on BMI score, weight loss score, and acute disease effect score. So based on these scores, it is categorized into low risk, medium risk, and high risk. In low risk, routine clinical care is enough. In medium risk, observation of the patient is important. In high risk, treating the malnutrition is important. And these are other nutritional screening tools: subjective global assessment, nutrition risk screening, mini nutritional assessment, and preoperative nutrition scores. Psychological and emotional support is also important. We have to adopt the stress management strategies. And lifestyle modifications, smoking cessation, alcohol reduction, encouraging the physical activity before surgery, all improving these lifestyle factors enhances the respiratory function. Risk assessment and tailoring, the baseline screening of physical, nutritional, and psychosocial aspects, risk stratification using the validated tools, individualized exercise prescription based on the baseline fitness. This ensures that interventions are safe and patient appropriate. So all these prehabilitation measures are important in onco patients.
Yeah, we know at one hand we have to look for the patient's comfort and the completeness of the therapy. At the other end, we need to balance the economical constraints or the economical implications of cancer therapy, because cancer therapy is not like a 1 day or 1 week's therapy. Once the patient comes, they need to shell out huge amounts of money on the investigations, on the surgery, on the different modes of cancer therapy. And so we need to have a structured or a modular approach to facilitate the faster recoveries and to improve the patient satisfaction, reduce the complications. For this thing, as we all know, the ERAS was introduced initially for colonic surgeries, and nowadays the ERAS has been extrapolated to each and every surgery. So, in this pretext, how ERAS is implemented in cancer surgeries, and what is the role of anesthetist in each phase of ERAS implementations? As because he is a perioperative physician who is involved in the preoperative, intraoperative, and postoperative phases, what is the role of an anesthetist in the implementation of ERAS for the patient's benefit?
Yes, sir. ERAS is important in onco patients. Enhanced recovery after surgery, which is multimodal, evidence-based perioperative care pathway to minimize the surgical stress and metabolic response, to maintain organ function, reduce complication, and promote early recovery and return to function. So why it matters in oncosurgery? Because it affects the short-term outcomes like hospital. It shortens the hospital stay, lessens the complications, and long-term oncologic outcomes because patient has to timely resume the other adjuvant therapies. And in the preoperative phase, along with the prehabilitative measures, which we have already discussed, along with that avoidance of prolonged fasting, carbohydrate loading to reduce insulin resistance, venous thromboembolism prophylaxis, avoiding routine mechanical bowel preparation in colorectal surgeries. And intraoperative phase, the use of short-acting anesthetic agents for rapid recovery, goal-directed fluid therapy, opioid sparing or multimodal analgesia, regional anesthesia and nerve blocks whenever needed, temperature monitoring and maintenance, lung protective ventilation strategies, and minimally invasive surgical approaches wherever feasible, and hemodynamic optimization. Postoperatively, ERAS emphasizes early recovery activities, early removal of tube, early removal of drains, early oral feeding, early mobilization, multimodal analgesia, glycemic control, P1V prophylaxis, and continued venous thromboembolism prophylaxis.
One thing the anesthetists are worried is about the airway assessment in cancer surgeries. Because when it comes to anesthetizing a patient who is having a cancer of head and neck region or of the aerodigestive tract, as you know, the incidence is really high. It's more than 50% of these cases have difficult airway, either because of the disease per se or because of the repetitive surgeries they undergo or because of the chemotherapy or radiotherapy they undergo and their effects on the respiratory system. How is airway assessment a little more extended or a little more comprehensive when it comes to cancer patients?
Yes, sir. Airway assessment in cancer patients, because of the cancer itself, oral cavity tumors, or because of the radiation-induced fibrosis, there will be difficult airway. Along with the normal history takings for difficult airway, history of difficult airway priorly, or history of difficulty in swallowing, difficulty in breathing, change of voice, previous radiation therapy or surgery, airway obstruction signs, and follow-up surgeries with radical resection and reconstructions. These histories are also important. And in the examination, along with the routine airway assessment, the cancer specific evaluation, tumor site, size of the tumor, nature of the tumor. If the tumor is friable, then there will be bleeding risk, which can increase the risk of aspiration, fibrosis, prismus. This evaluation is also important. And advanced tools such as airway imaging, X-ray soft tissue to see any deviation or compression of the trachea, indirect laryngoscopy to assess mobility of vocal cords, CT scan to see compression and extent of the tumors, bronchoscopy, virtual endoscopy, 3D reconstructions, and flow volume loops. And discussion with the surgical team. Requirement for the surgery, for of what type of tube is required for the patient for that particular surgery, whether oral endotracheal tube or nasal endotracheal tube, laser tube, or double lumen tube. Based on the requirement of surgery, will decide. And availability of resources, video laryngoscopy, fiber optic bronchoscopy, and expertise with those instruments. And rescue plan, as a backup plan, we should keep front of neck access always ready.
Rakshita, you have comprehensively covered that airway assessment when it comes to cancer patients needs a careful history taking, bedside examinations along with the routine measures like indices and other things, review of the investigations, and one specific thing is discussion with the surgical team because in most of the surgeries which is pertaining to head and neck region or in thoracic region, shared airway and management of shared airway is of a great challenge for the anesthesiologists. Okay, that you have comprehensively covered. As you have already told, these cancer surgeries are very invasive. They involve lot of fluid shifts and they come with major blood loss. Okay, the blood loss is very huge in cancer surgeries. How is the blood management strategies that is being practiced in cancer surgeries?
Yes, sir. Blood management strategies in cancer patients are crucial because cancer patients will be having baseline anemia, malnutrition, marrow suppression, and the procedures are often long, extensive, and associated with major blood loss. So, patient blood management involves preoperative detection and optimization of anemia, coagulation correction, intraoperative blood conservation techniques, use of antifibrinolytics and viscoelastic guided transfusion, restrictive transfusion strategy, and postoperative vigilance. So, along with the preoperative strategies, intraoperative strategies include surgical techniques and the anesthetic techniques. Surgical techniques, the meticulous dissection using energy devices and topical hemostatics application. Anesthetic techniques, the controlled hypotension to reduce bleeding, normothermia, goal-directed fluid therapy, and use of antifibrinolytics. And viscoelastic guided transfusion, that is targeted component therapy, PEG or ROTEM guided algorithms, which will reduce the overuse of other components. Cell salvage is controversial, but it is increasingly used. Previously, it was avoided due to fear of tumor cell dissemination, but now it is used with leukocyte depletion filters and irradiation in some centers. Acute normovolumic hemodilution is used in selected patients. Postoperative strategies, early detection of bleeding, minimizing drains wherever possible, continuing the restrictive transfusion triggers, and DVT prophylaxis. And restrictive strategy is used. Why it is important is because of transfusion-related immunomodulation, which can cause allogenic sensitization, possible association with tumor recurrence, and increased infection risk. So we'll keep as transfusion trigger hemoglobin for stable patients 8 gram per deciliter, whereas in cardiac patients 9 gram per deciliter.
Yeah, you have rightly covered, Rakshita, that on one hand, the patients will be anemic either because of the disease or because of the chemotherapy or radiotherapy induced myelosuppressions and the long surgeries. Even there is a lot of revolution in the surgical techniques with the invention of minimally invasive surgeries, the introduction of high energy devices like harmonics, staplers, and with the advancement in anesthetic techniques per se, with the use of the TEG and ROTEM, where we use a component therapy, okay, that is a guided component therapy to reduce the transfusions, because we know that all these will have an impact on the tumor recurrence or immune surveillance. Okay, that is the reason restrictive transfusion therapy is being practiced in oncosurgery. As we all know that oncosurgeries involve major fluid shifts, okay? Be it be because of the draining of ascites or because of the pleural effusions or because of huge third space loss, okay? Or the prolonged surgeries which involves and the many of the patients will not be able to take enough orally or IV lines, okay? because of the difficult IV access or because of difficulty in swallowing. Most of these patients come dehydrated or will be in a hypovolemic state. And these surgeries over and above, they have lot of fluid shifts. With this scenario, how is the fluid management done in cases of oncoanesthesia?
Yes, sir. Fluid management strategies in oncoanesthesia, it is complex and individualized because patients will be having malnutrition, hypoalbuminemia, chemotherapy-induced cardiomyopathy, nephrotoxicity, massive surgical dissection, inflammatory capillary leak, and risk of pulmonary complications. So, goal-directed fluid therapy is the standard of care in major oncological surgery. It uses dynamic indices, stroke volume variation, pulse pressure variation, esophageal Doppler, and arterial waveform analysis. Preoperatively, assessing the volume status and correcting the deficits is important. Patient may look cachetic and dehydrated, but assessment of intravascular volume is important. In case of GI cancers, because of obstruction, there might be chronic fluid loss. And if patients has undergone cisplatin chemotherapy, then it is nephrotoxic, which can cause renal impairment. So assessing volume status is important. And correcting the deficits with balanced crystalloids, avoiding prolonged fasting, and carbohydrate loading whenever it is appropriate. Intraoperative fluid strategy is to maintain euvolemia because overload can lead to pulmonary edema, anastomotic leak, delayed bowel recovery, wound complications, and under resuscitation can lead to acute kidney injury, hypotension, lactic acidosis, organ dysfunction. And the fluid of choice is balanced crystalloids, ringus lactate, and plasmolite. Colloids has a limited role. The synthetic starches are generally avoided because of its renal impairment risk. Vasopressor supported restrictive strategy. Instead of giving excessive fluids, early use of norepinephrine will be helpful. It avoids interstitial edema also. And in special oncologic surgeries, like in case of cytoreductive surgeries and HIPEC, there will be massive third space loss, hyperthermia, which can lead to vasodilation. So requires invasive monitoring, frequent ABGs and electrolytes and corrections. In liver resection, low CVP is maintained. We have to maintain during the parenchymal transection, and after transection, we will restore the volume. Head and neck cancer cases, excessive fluids can lead to airway edema. In thoracic surgeries, restrictive fluid therapy with lung protective ventilation will be helpful. Excessive fluid can lead to ARDS. Major pelvic and colorectal surgery, excess crystalloid can lead to anastomotic leak. Postoperative fluid management, stopping IV fluids early oral intake in adherence with TERA's protocol, avoiding maintenance fluids, and strict input-output charting is important.
So, Rakshita, you mean to say that instead of going for either a liberal fluid therapy or restrictive fluid therapy, goal-directed fluid therapy is the gold standard in the fluid management in oncosurgery. Assessment of the patient's volume status in the preoperative period, maintenance of euvolumia in the intraoperative period using dynamic indices, and in the postoperative leave, following the ERAS protocol, avoiding massive fluid transfusions, removing the early drains, discontinuation of the IV fluids early, encouraging the oral fluids, help to maintain the fluid strategies. Yeah. So, Rakshita, can we consider that oncoanesthesia, because of the increasing cancer trend, more and more patients are coming for cancer surgeries, not only in tertiary setups like us, but more in secondary and even primary centers are facing with a huge burden of cancer cases. And to maintain these cancer cases and to deliver an optimized holistic perioperative approach, oncoanesthesia is needed. To deliver that effectively, you need to anticipate the preoperative challenges, optimize these patients throughout the perioperative period, have a patient blood management, fluid management, pain management strategies. Okay, with this in view, how can we conclude that we require oncoanesthesia as a subspecialty?
Yes, sir. Because oncology surgery presents unique challenges to anesthesiologists, considering the time-sensitive nature of surgery and return of intended oncological treatment, optimization of illnesses is challenged. So, thorough preoperative assessment, optimization, and prehabilitation is essential for the positive outcome of the patient.
Thank you, Rakshita. As you have rightly said, all of us work for the patient's safety, patient's safe and complete recovery, and to ensure that all cancer patients receive a comprehensive care. That is where the anesthesiologists come into picture, not only confined to intraoperative period. That is where we need to get involved with the patient's optimization in the preoperative period, deliver the safe anesthetic techniques in the intraoperative period, follow them up in the postoperative period, ensure adequate pain control, ensure adequate postoperative nausea and vomiting, and with your active involvement and the rehabilitation and the prehabilitation processes, see that the patient returns to the intended oncological therapies as soon as possible. And even in case the oncologists are also involved in palliative therapies, so to ensure a comprehensive care for the patients. Okay, that is how oncoanesthesia is has to be looked at, and oncoanesthesia where it stands. Thank you very much, and we'll take up a few multiple choice questions on the topics that is being covered. And I request all the participants to mark their answers for these multiple choice questions in the chat box. No problem.
The first question, prehabilitation in cancer patients primarily aims to: option A, determine tumor staging before surgery. Option B, improve baseline functional reserve before surgery. Option C, select the appropriate anesthetic technique. Option D, adjust intraoperative ventilator settings.
Most of them have answered option B. All of them have answered
Yes.
option B.
Yes,
Even
That means they,
even before you could finish, they have answered B.
yeah, that is how well she has conveyed the class, madam.
I know, really.
Next, we'll go to the next
Yeah.
question.
next question. Which of the following is the most important airway concern in patients with head and neck cancer after radiotherapy? Option A, increased airway compliance. Option B, tissue fibrosis leading to difficult laryngoscopy. Option C, excessive airway secretions. Option D, hyperactive airway reflexes.
Answer is B. All of them are answering B.
No, wait. Give them some time.
About 10 seconds we can give.
Give them some time. Everyone will not answer fast. Give them time. Meanwhile, Subhalipsa, you just note down who gave the first correct answer. You
Yes, ma'am.
can give the name of that person who has given the correct answer. And also note down who is the person who is answering maximum questions, okay?
Yes, ma'am.
Department of Anesthesia, Kidwai Memorial will send them gifts. All those
Yeah,
who are
sure,
answering
madam.
well.
Sure, madam. Sure.
Oh, yeah,
From
yeah.
ISA National and ISA Karnataka, we'll give them, madam.
Sure. Chalo. Answer.
They're answering B.
Yes, it is correct answer.
Third question.
What is the preferred intraoperative fluid strategy in major oncologic surgeries? Option A, liberal fluid therapy. Option B, restrictive fluid therapy. Option C, goal-directed fluid therapy. Option D, zero balance fluid therapy.
They're answering it as C. Nikhila is the first person to answer. C. C is the option. Goal-directed fluid therapy.
Yes, correct answer. Question number 4. What is the preferred fluid of choice in major oncological surgery? Option A, normal saline. Option B, 5% dextrose. Option C, balanced crystalloids. Option D, hydroxyethyl starch.
They're answering C.
C, correct. Ringer.
Crystalloid.
Yes, correct answer. Last question. In a patient with ongoing intraoperative bleeding, the most appropriate strategy for blood component transfusion is option A, transfuse blood components based on hemoglobin level alone. Option B, transfuse based on clinical estimation alone. Option C, transfuse based on conventional coagulation tests. Option D, transfuse based on viscoelastic testing.
Is also B, I think.
Yeah, they have started answering. Rohit has given the first right answer. D.
Yes, correct answer.
Now let us move on to a class from didactic lectures or interaction to video sessions, which is of more practical importance and probably everyone is waiting to see. This is one of the major thing in oncoanesthesia and thoracic anesthesia, even in cardiac anesthesia also. So I request our professor and HOD Aarti madam to continue the session.
Thank you. Thank you, Dr. Hinjappa. It was a very comprehensive lecture on demystified the oncoanesthesia challenges. One lung anesthesia. Now let us not waste time. We will go to, it's done, Dr. Nazrin? Yeah. Yeah, one lung anesthesia, we learned about comprehensively what are the difficulties, challenges we come across in anesthesia, oncoanesthesia. Among them, one of the very interesting and challenging field is one lung anesthesia. Nowadays, with so much of advancement has happened in surgical, what happened? So much of advancement in surgical field, the requirement of one lung anesthesia has become demanding. That one lung anesthesia is very interesting when we teach the students. But when you are doing it practically, it gives a lot of challenges. So when I approached Dr. Madhuri Madam, my teacher, that I want to do one lung anesthesia, she said many times it has been covered already. Then I said, Madam, something called troubleshooting is very important. Then she gave me consent to go ahead with troubleshooting. So this particular talk, what we are doing is not only basics of one lung anesthesia. Here we are going to cover up what are the problems we commonly come across when you do practically lung isolation and how do we rectify it. That is what we are concentrating more on this. And we have some of video sessions where you understand, some of the pictures where we make you understand. This is the whole challenge, what we are having it today. And I have with me my student, final year student, Dr. Nazreen Nisha, to present the mastering the lung isolation. How do we anticipate? How do you check the problem? And how do you treat the problem? So Nazreen, you can start your presentations now.
Good evening, everyone. My topic is Mastering Lung Isolation, Anticipation, Accuracy, and Action. Greetings from our institute, Kidwai Memorial Institute of Oncology.
So when you see this picture, there's one introduction I want to tell. Why this lung isolation concept came into picture. Though lung appears as one unit, it is independent morphologically or anatomically. This concept has been utilized to make lung isolation. Over the years, it has come with various changes, various advancement, various techniques, which has helped us to isolate the lung and helped in surgical field as well as many indications that we are going to see then in future.
So indications of lung isolation. There are two indications, absolute indication and relative indications. The absolute indications are to prevent or to protect the healthy lung from the contaminated lung. Contamination in the sense lung abscess or pulmonary hemorrhage, or to control the ventilation, or to provide a unilateral bronchoalveolar lavage. So this is example, bronchopleural fistula. The other is to facilitate the single lung lavage. Unilateral lavage is bronchoalveolar lavage. The relative indications are to facilitate the surgical exposure and access, and in case of thoracic aneurysm surgeries, lung volume reduction surgeries, pneumonectomies, esophageal surgeries, there are relative indications.
So this is how you should remember the absolute indications. Whenever we ask students, they will not remember what are the absolute indications of lung isolation. Whoever students are attending this class, please remember the absolute indications for lung isolation. Nazreen, can you go ahead with the techniques of lung isolation?
There are two techniques. One is by using double Newman tube. The other is bronchial blocker. So what is double Newman tube? Double lumen tube was first introduced in 1931 by Gales and Waters, and it is essentially two tubes which is joined together side by side, and it is now functioning as a single tube, and it facilitates independent connection to a separate breathing system or to a same circuit. So parts of DLT. The DLT has different parts. One is connector and two different lumens and two different cuffs and pilot balloons. The one is white in color, that is tracheal cuff, and the other is blue in color, that is bronchial cuff. And it has separate pilot balloons for inflation. The tracheal lumen and the bronchial lumen is of unequal length. The tracheal lumen exits just before the bronchial lumen. The bronchial lumen end is at the tip. Types of DLT. There are various types of DLT: Carlens, White's, Bryce-Smith, and Robert Shaw. Carlens has hook and White has hook, whereas Bryce-Smith and Robert Shaw doesn't have hook. They have left-sided and right-sided separate DLTs.
The hook means it is carinal hook. If you can see in the picture down, there is one projecting area which was introduced earlier because we were having a lot of failures when we placed the DLTs. So they introduced carinal hook so that it fixes at carina and the DLT goes to the desired side of the lung. But over that time, we realized that trauma with the carinal hook, because of the anatomy variation, we were not able to place it properly. So over that time, the carinal hook was removed, and now at present, we do not have. It's just a history and for people to know what is carinal hook.
So right versus left DLT. So how will we select the side? Right and left DLT differ in basic because of their anatomical differences between right and left main bronchus. The right upper lobe bronchus is located more proximal to the carina than compared to the left upper lobe bronchus. This is a picture showing the left-sided and right-sided DLT. The right-sided DLT has special opening to ventilate the right upper lobe. So this is the right side and this is the left-sided DLT. So left-sided DLT are more commonly used and because it has ease of insertion and better margin of safety, whereas right-sided is used only for few indications because of technical and technical issues, and it is complicated to insert and more frequent displacement is there, and it has less margin of safety. So where and all we can use the right-sided DLT? Surgeries like left pneumonectomy, left lung transplantation, left bronchial disruption, left-sided thoracoscopic surgery, or any distorted anatomy of left main bronchus.
One thing all of us should remember, whenever the point is very important for students, I'm interfering, the margin of safety that all students have to remember. Margin of safety is a point where you can move the double lumen tube or the limb of the bronchial lumen of the double lumen tube further forward and backward without affecting the oxygenation, without affecting the ventilation and oxygenation. If you see in this, the red arrow, which is shown on the left side, is the margin of safety, which is about 5 centimeters in left DLT, whereas it is about only 2.2 to 2.5 centimeters in right side of the bronchus, where the other upper bronchus branches out from the right. So with this picture itself, we can understand left DLT insertion is safer and easier.
So sizes of DLT, how will we select the size? In 1995, they used gender-based system. Female means 35 to 37 French, male 39 to 41 French. In 1997, they used height-based system. Height less than 162 centimeter, 35 French, 160 to 170 centimeter, 37 French, and 170 to 180 centimeter, 39 French. More than 180 is 41 French. In 2003, they have used X-rays to measure the tracheal width, and tracheobronchial ratio is used to calculate the DLT size. In 2007, they have used CT scan to measure the diameter of trachea on the bronchus. Now, the recent advancement is CT-based virtual endoscopy. That is an advanced airway imaging. This picture shows the virtual endoscopic image.
There's so many advancement has happened in identifying to make to assess the accurate size of the DLT. But invariably, we still are stuck with the height-based and the sex-based assessing the tube size while you are using the double lumen tube.
So insertion of DLT, how to insert the DLT. This is a video representing the insertion in our
If you can see, we have taken a left-sided DLT. You can see that DLT should always go with the styletin. The moment the bronchial cuff has gone inside the larynx cards, the stylet is removed. If you can observe, there is 90-degree rotation. Exactly 90-degree rotation is something very, very important when you are inserting DLT. And if you can see, I have seen the resistance and I have taken out the tube and we are fixing it. We are checking that how the DLT placement is checked. Dr. Nazreen will explain now.
So depth of insertion, first we have, as ma'am said, so after the resistance is felt, we have to stop inserting it further. So based on the height, we can calculate the depth of insertion. If the height of the patient is 170 centimeter, the depth of insertion is approximately 29 centimeter. The depth varies by 1 centimeter for every 10 centimeter variation in height. So this can be calculated by using the formula height divided by 10 plus 12.
How do we confirm the DLT placement? Where are the methods? What are the methods?
Yes, ma'am. There are two methods. First one is by auscultation. The other one is gold standard by fiber optic method. First is auscultation, that is sequential clamping and auscultation, 3-step method. First, after placing the correct size DLT, we have to inflate the tracheal cuff with minimal volume and auscultate for bilateral air entry. Once there is bilateral entry, we have to clamp the tracheal lumen of the DLT. Then inflate the bronchial cuff with minimal volume of air, 1 to 3 ml, then auscultate on the right side and confirm there is no air entry on the right side. And release the tracheal lumen clamp and close the port, then auscultate for the confirmation or resumption of the bilateral air entry. Then followed by confirmation by fiber optic bronchoscope. This is the gold standard technique. For the left-sided DLT, we have to place the fiber optic bronchoscope to the tracheal lumen and visualize the sharp carina and the blue rim of the bronchial cuff. Whereas we have to insert the fiber optic bronchoscope to the bronchial lumen and visualize the secondary carina of the left side. In right-sided DLT, we have to insert the same through the tracheal lumen and visualize the carina along with the blue rim of the bronchial cuff. And again, we have to insert it to the bronchial lumen of the double lumen tube to confirm whether it is in the right side bronchus by visualizing the right upper lobe, middle lobe, and lower lobe orifices. So what are the complications of DLT? So DLT, the most common complication is malposition, later airway trauma, and the last one is tension pneumothorax.
So coming to the another method of lung isolation is bronchial blockers. And because of the time constraint, we are just giving one introduction about bronchial blockers, and we are going ahead with the troubleshooting. Continue this focus.
So bronchial blockers is an alternative technique to achieve lung isolation. It can be used to provide selective lobar collapse. It is placed intraluminally within the single lumen tube, that is coaxial placement, or placed separately beside the endotracheal tube. It is used in difficult airway situation or when the DLT placement is difficult. There are various types of bronchial blockers. One is ARNT blocker, univent blocker, Cohen's blocker, and EZ blocker.
So now we are coming to the main part of our discussion, troubleshooting. When we started discussing the beginning only, I told it's very rosy and very nice to listen how we are going.
Snigdha, 16 or 7.
Somebody has to mute, yeah. So as we discussed already, malpositioning is one of the commonest complication we come across when you place the DLT. Sometimes while placing the tube itself, we are not able to pass it properly, or even after placement when you are giving position. So it is so significant. There is a lot of literature has come on malpositioning. So the literature says up to even 54% of the patients, even skilled providers, are having malposition. Seeing this, then there is an article. So how do you define malposition, Dr. Nazri?
Based on the study by Campos et al., he defined the malposition as bronchial cuff more than halfway out, or it is not visible at all in the entrance of main bronchus, or it is in the opposite bronchus. Then the tube needs to be moved more than 1 centimeter to correct this position.
So when it happens, actually, as I told you, it is during the position or after, during placement or during the positioning.
So most commonly, DLT malposition happens during DLT placement, when the DLT may be unintentionally be directed to the incorrect side of the target mainstem bronchus during placement, or after placement, like transferring the patient from supine to lateral position in thoracic surgery, as like if the patient has neck flexion or extension or surgical manipulation may cause the displacement of the DLT.
In 2022, IJA published a beautiful article with algorithm on difficulty in DLT placement. We took this article, it has 4 limbs. We have divided the 4 limbs into separate, and we thought we will understand each limb properly and the remedies to it. Let us see each limb one by one.
So now in this scenario, this DLT is not reaching the vocal cord.
So the first limb of the algorithm says DLT not reaching the vocal cords. We found a video when we were not able to pass the tube, bronchial cuff of the DLT. In the DLT, first thing to go through the cords is blue color, double lumen, bronchial lumen of the part. Here we are not able to pass through it. So how do you manage? What is the remedy to it?
If the DLT is not reaching the vocal cord, we have to thread the bronchial lumen of the DLT over the fiber optic bronchoscope. So after entering the bronchus, slide the DLT over the fiber optic bronchoscope, as in this picture. Or withdraw the DLT 1 to 2 mm outside and ask the assistant to flex the neck of the patient. Or withdraw it completely and bend the distal end of the double lumen tube like a hockey stick and retry.
This is one of the commonest thing which we do even in a conventional technique. When we are not able to do, we make it a hockey stick and intubate. Same technique can be used in DLT, or we can ask the patient to even flex the neck of the patient so that we can negotiate through the cords.
This is the video showing that how we will bend the double lumen tube end as a hockey stick. So now the second scenario is DLT stuck at the glottic opening.
So here we are able to negotiate. It is stuck. We are not able to push it further through the cords. It is gone there. It is not. We are not able to push it further through the cords. So what can be done, Dr. Nazreen, then?
So in these scenarios, we have to try a smaller size DLT or rotate 30-degree clockwise, or you can use single lumen tube with bronchial blocker. At final resort, we can use PROA with jet ventilation.
The best would be to take out a smaller DLT, but always you think about the complication of smaller DLT. You may not be give adequate lung isolation. So you can get used to this rotating 30-degree clockwise. Sometimes the size is adequate, but it does not get negotiated through the cords. So like this.
So this is the video showing how we are making a 30-degree rotation.
You can see in this, we negotiated and we did a screw type 30-degree rotation to push the tube, and we were able to isolate the lung very well in this particular case. You can see even rotating 90-degree towards the side to be placed, and the resistance felt also.
So the next scenario is DLT positioned in the wrong side.
So here we didn't want to experiment on patients, so we took a mannequin. Intentionally, we tried how you can place it in a wrong side. If the DLT goes to a wrong side, what can be done? Next one.
So if the DLT is positioned on the wrong side, so we have to withdraw the DLT completely and reinsert, as I already said, increasing the curvature of the DLT. Or insert the fiber optic bronchoscope via the bronchial lumen, withdraw the DLT till the blue cuff and the bronchial lumen is above the carina and reinsert. If in case of left-sided DLT, rotate to left side, and in case of right-sided DLT, rotate to right side.
Yeah, this is the video where we corrected. The very important, what I want to emphasize on this, use the fiber optic scope. Nowadays, we don't get the fiberless scopes actually. So you can twist and turn however you want. Earlier, we used to always get worried the fibers will get spoiled. Now you can use a kind of, it's not fun, fiberless optic scope as a stillet. You take out and take the fiber optic scope, and because we are so used to say fiber optic scope, and use it like a stillet, and you can guide your bronchial lumen towards the desired side. Like for example, you want to right side, you put it and then guide it. This is what we wanted to show in this particular video, to use fiber optic scope as a stillet.
So now we are moving on to the malposition after placement.
So we all learned that malposition which can happen during the placement of the double lumen. Now we are placed and we have to put the patient into a position, and now we check suddenly there is a change, or we are not able to hear the breath sounds, and various scenarios we come across. So we chose some 5 scenarios here for everybody to understand what are the common scenarios you come across after you place the DLTs. So Nazreen and myself have made some 5 scenarios here with a picture. I hope we are able to make everyone clear about the problems. So coming to scenario number 1, in all the scenarios, I have used a left-sided double lumen tube. So in this scenario, I have put a left-sided double lumen tube, and I have inflated. Kindly all of you make an image of the DLT going into the lungs. On inflating the tracheal cuff, I auscultate bilaterally equal breath sounds. That is the conventionally how it should be. Then I inflate both the cuffs, that is tracheal cuff and the bronchial. First, I will clamp the tracheal lumen, and then I hear breath sounds absent on the right side. And I clamp the bronchial lumen, then breath sounds are absent on the left side. When I clamp tracheal, breath sounds are not heard on the right side, and I release it and clamp the bronchial, breath sounds are not heard on the right side. What is your interpretation, Nazreen, and how do you explain to it?
This is the properly placed left-sided DLT. This is a picture showing the left-sided DLT is correctly placed, and the bronchial lumen is correctly sitting on the left bronchus, and the tracheal lumen is present in the trachea.
This is exactly in a correct placement. You will not be able to hear right-sided breath sounds when we clamp the tracheal lumen, and when we clamp the bronchial, left side is not, breath sounds are not heard.
So this we can confirm it with the fiber optic bronchoscopic view, as I already said. So we have to see the sharp carina along with the blue rim of the bronchial lumen. So in these scenarios, we have to fix the DLT properly so that it won't get displaced while positioning the patient.
So now coming to scenario 2. So we understood correct placement. Always you should know the normal things before you understand abnormal. So here again I put a left-sided DLT. On inflation of tracheal cuff alone, I'm supposed to auscultate. I'm supposed to hear breath sounds equal on both sides. Here I'm not able to hear breath sounds on the right side. Okay, then I go and inflate both the cuffs, right side as well as, tracheal as well as bronchial cuff. Then I clamp the tracheal lumen. Now here, breath sounds are absent on the right side. Ideally, it should have been, breath sound should have been absent. It is absent. Then I clamp the bronchial lumen. There is minimal air entry which is happening on the left side. So what is the scenario? How do you explain, Dr. Nazreen?
In this scenario, both the bronchial cuff and the tracheal cuff has gone deep inside the left bronchus, as seen in the picture. So both the bronchial cuff also and the tracheal cuff also went so deep inside the left bronchus. So there is no air entry going to the right side bronchus. Since the tracheal lumen is inside the left bronchus, so some amount of air is going to the left bronchus even after inflating the tracheal lumen and bronchial lumen.
So both have gone one side. That is why right side is completely no air entry, which should have been conventionally used when we use it like a single or with the tracheal cuff. So what is your fiber optic view?
So fiber optic view through the tracheal lumen shows flat carina along with a small rim entering into the left bronchus so deeply, and the fiber optic bronchoscope through the bronchial lumen is not going further into the branches of left upper lobe and lower lobe.
Always we have to understand how do we identify the two carina. Primary carina is always a sharp and a secondary carina is always looks blunt. That we have to remember.
So in these scenarios, we have to withdraw the DLT under fiber optic guidance till the tracheal lumen opening lies in the trachea.
Good. Now going to scenario 3, here again DLT is placed. On inflating the tracheal cuff, I can hear bilateral breath sounds equal, which is normal, which should have been like that only. Then I inflate both the cuffs. I inflate the tracheal as well as bronchial cuff. Then I clamp the tracheal lumen. I hear bilaterally equal breath sounds. Ideally, I should not hear breath sounds on the right side, but I'm able to hear bilaterally equal. Okay, then I clamp on the bronchial lumen. Again, I hear bilaterally equal breath sounds. What is the interpretation, Nazreen?
In this scenario, both the tracheal cuff and the bronchial cuff are in the trachea alone. So in this picture, so both the bronchial cuff also and the tracheal cuff also lies
inside. Tube is working like our regular conventional tube. So we are able to hear breath sounds on both sides, whatever we are blocking. Other tube is ventilating.
So in the fiber optic view also, we are seeing both in the tracheal lumen also, bronchial lumen also, the free carinal end. So in these scenarios, we have to rotate the DLT 90-degree anti-clockwise and push the DLT down till the bronchial lumen enters into the left bronchus, and only a small rim of the blue cuff should be visible in the fiber optic.
Similar, we seen recently, we done a case like this. Then we had to use fiber optic and we directed towards the left side. Coming to the scenario 4, here again after DLT is placed and I inflate the tracheal cuff, I hear bilaterally equally breath sounds. Then I inflate both the cuffs and clamp the tracheal lumen. Now breath sounds are absent on the right side, which should have been there, which is absent to the right side is normal. Again, I clamp the bronchial lumen. Now bilaterally breath sounds are absent.
So in these scenarios, there is a herniation of the bronchial cuff into the main trachea and it is obstructing the right bronchus also. So this most commonly seen during positioning of the patient, or when there is a tracheal deviation and the carinal deviation towards the right side, or when there is a very narrow left bronchus. So this is a picture depicting the herniation of the bronchial cuff to the right bronchus so that it obscuring the air entry to the right bronchus.
This is one of the commonest complication you come across. You place the double lumen tube, you feel everything is perfect and you inflate with the over enthusiasm, you inflate the bronchial cuff more, it just herniates back. When you place the patient in position, then you fear this complication, you come across this kind of scenario. This is the commonest among all the scenarios.
So in the fiber optic view also, we can see the bronchial cuff has been herniating and it is obscuring the right side bronchus. So during the situations, we have to insert the DLT few millimeter deeper under fiber optic guidance till the blue cuff disappears into the left bronchus. In this scenario is most commonly seen when there is a carinal lymph node or mass presence. In that situations, we can use bronchial blocker if the herniation persists.
Now coming to our last scenario, here again I've inflated the DLT, inflated the tracheal cuff, and I hear bilateral equal breath sounds. Then we inflate the both tracheal and bronchial cuff. Clamp the tracheal lumen, then I hear breath sounds are absent on the left side. Ideally, it should have been absent on the right side, but here it is absent on the left and at right upper lobe. Then I clamp the bronchial lumen, the breath sounds are absent on the right side. What is your interpretation?
Now the double lumen tube has gone to the wrong side. The left sided DLT has gone to the right side. So the bronchial cuff and the tracheal bronchial cuff is in the right side and is obscuring the right upper lobe ventilation. That's why during right sided clamping, the breath sounds absent on the left side and right upper lobe is also absent.
So how do you give a remedy to everyone? Fiber optic view, yeah.
Fiber optic view shows only one bronchus. The left bronchus is not seen, and the bronchial lumen of the DLT with the blue cuff disappearing into the right bronchus, and through the bronchial lumen, right upper middle lobe and the lower lobe bronchus is seen. So in this scenario, we have to using the fiber optic bronchoscope, withdraw the DLT till the bronchial lumen lies above the carina and rotate the DLT 90-degree anti-clockwise and push it further till it bronchial cuff enters the left bronchus and a blue rim is seen.
So with all this, there are some, we want to highlight on some newer techniques which helps us to place the accurate placement of the DLT with the less complications of malposition.
The newer techniques are anchor DLT. It was invented by Young Jen and it has an additional carinal cuff that is situated at the point between the distal opening of the tracheal lumen and the beginning point of the bronchial cuff. So this is a green carinal cuff. It sits correctly on the carina. So it is most commonly used when the fiber optic bronchoscope is not available or the bronchoscope cannot pass through a narrow lumen DLT, that is less than 32 French. The next is ambu viva side DLT is an improvement over the blind insertion technique. It has an integrated camera attached at the distal end of the tracheal lumen. So each step of the DLT placement is displayed in a specialized screen. Next, at the last resort, high frequency jet ventilation using FROVA. So this provides a tidal volume of less than 2 ml per kg at a rate of 60 to 900 breaths per minute. High frequency jet ventilation can be administered via FROVA-like intubating catheter in difficult airway situation.
The jet ventilation is very common, but not a new thing. It has been there from years. What is one of the dreaded complications, Nazreen, with the jet ventilation?
It's hypercarbia, ma'am. So ABG analysis is frequently needed during jet ventilation.
That is what very much you should be careful when you're using jet ventilation. Learn the technique well and use jet ventilation if you want to use. So how do you isolate the lung with a patient with a tracheostomy?
So placing lung isolation devices through a tracheal stoma is high risk of malposition and complete airway loss is possible. So whereas there are various options available to obtain one lung ventilation in tracheostomized patient. For example, removal of tracheostomy tube and inserting a conventional DLT through the stoma, or removal of the tracheostomy tube and inserting a single lumen tube through the stoma followed by the bronchial blocker, or bronchial blocker can be coaxially administered along with the cuffed tracheal tube, or replacing the tracheal tube with a specially designed short DLT, that is Naruke DLT, or removal of the tracheal tube using standard orotracheal placement of DLT and bronchial blockage.
But Naruke tube will be more useful. Can you just show the picture of Naruke tube?
Yes, ma'am. So Naruke and the colleagues developed modified reinforced silicon double lumen intrabronchial tube tailored for tracheostomized patient. So it is more flexible and it is made up of silicon, so it reduces the trauma. The wire reinforcement prevents kinking, so reliable lung isolation is available. It is quick to place and it provides very minimal airway irritation and stable fixation at the stoma.
And even dead space will be reduced. So now we are coming to the end of this. We have kept some case scenarios. Where time permits, we'll just go ahead. Is that?
So a 69-year-old male smoker with COPD has a right upper lobe lung nodule posted for VAD surgery, and he's 163 centimeter tall, weighs 75 kg and has a BMI of 28. On chest X-ray, his tracheal diameter is 16 mm and placement of 39 French left DLT is planned. After induction of general anesthesia, intubation is attempted using video laryngoscope. A full view of glottic opening is obtained. The passage of DLT is met with resistance, so an 8-size endotracheal tube is placed and the patient is ventilated, while a 37 French, that is smaller size DLT, is prepared and the tube exchanger is deployed. So 8-size endotracheal tube is withdrawn and attempt made to place a smaller size DLT. This smaller size DLT also went with resistance. So upon examination through video laryngoscope, it is clear that resistance is at the level of glottis. So further attempts of DLT is aborted.
So what is your remedy resolution to this? So people can answer in chat box also if anybody has any doubts with this. Okay, what is the resolution?
So in this 8-size DLT is placed, but the bronchial blocker is positioned by means of fiber optic bronchoscope for lung isolation. Since the double lumen tube met with the resistance, so alternative technique like bronchial blockers should be used. So this case demonstrates the challenges that are occasionally faced during the double lumen tube placement. Though the tracheal diameter is adequate, the glottic opening or angulation can hinder the placement of the DLT. So jaw lift combined with gentle clockwise rotation of the DLT might also be useful. So even when the multiple attempts are unsuccessful, better go with the conventional double two lung.
Whatever videos we showed was similar to this problem.
So case scenario 2, a obese 76-year-old male with a left lower lobe tumor scheduled for VATS and wedge resection. He is 172 centimeter tall, weighs 92 kg and BMI of 31. After induction of general anesthesia and a placement of 41 French left-sided DLT is planned, and the patient is placed in right lateral decubitus position. Now bronchial cuff is inflated and lumen is clamped to establish lung isolation. So ventilator setting, volume control ventilation with tidal volume of 325, respiratory rate 16 breaths per minute, FiO2 80 and PEEP of 5. Then surgeon started the surgery. Several minutes later, the colleague noticed that the patient saturation dropped from 98 to 90%, and in that response, he increased the tidal volume to 550 ml and FiO2 to 100%. Now the patient saturation is 90%.
Is it right to, do you want to continue with FiO2 of 100%, or do you have some other solution? Because FiO2, high FiO2 can cause volutrauma, hyperoxia.
Yes, ma'am. Since the patient is obese, so it is preferable to give a gentle recruitment breaths, or since the abdominal compression will be more in obese patient, slightly increasing the PEEP will help. So prolonged increased FiO2 will cause volutrauma, barotrauma, and oxygen toxicity. So better to go with low if the saturation improves, better to reduce the FiO2.
Most of the time, gentle recruitment breaths will help us to improve the FiO2 and increasing PEEP.
So case scenario 3, a 58-year-old male smoker diagnosed as non-small cell lung cancer involved a large portion of left lower lobe and extending to the left mainstem bronchus and planned for left pneumonectomy. So in this situation, we have used 41 French right-sided DLT. So the position is confirmed with the fiber optic bronchoscope. The patient is positioned for surgery. 30 minutes later, after the lung isolation is achieved, SpO2 decreases from 96% to 89%. So for which FiO2 is increased to 100%, and circuit is checked for leaks, kinks, and disconnection. Even ventilatory settings and capnography reveal no significant changes, and the fiber optic bronchoscope is used to confirm the appropriate positioning of the DLT. Recruitment breaths are also given, and the PEEP of the ventilation is increased from 5 to 8. The SpO2 temporarily increased to 94, but eventually drops to 88%.
So what is your resolution to it?
So this is in this situation where all the common cause of hypoxemia is ruled out, then final resort is clamping the pulmonary artery.
Clamping the pulmonary artery, how does it help?
So clamping the feeding vessel to the lung segment will reduces the shunt fraction and activate the hypoxic pulmonary vasoconstriction and improves the speed.
So always we should remember about hypoxic pulmonary vasoconstriction when we are giving lung anesthesia. That is why physiology of one lung anesthesia is very important to understand. So though it is theoretically, in my experience, I have not seen clamping the pulmonary. With the recruitment breaths, we are able to manage most of the hypoxia. This is quiz. So now we thank you all for listening to this, and we have quiz now. Can we go ahead with a quiz? What is it her name? Subalipsa. Start asking.
Subalipsa and Sagarika.
Yes.
Sagarika, can we go ahead with our quiz?
Yes, ma'am.
The first quiz is they have to type this, see the video, and give us the answer in the chat box. This is not option. This is that they have to tell.
What is wrong in this video?
What is wrong? What is wrong in this DLT placement? Okay, this is one.
There is only one answer, ma'am. Dr. Anupriya. Okay, two answers.
Just the video is just now over. Maybe we can give 10 seconds time.
Wait, give them time.
Give them 10 seconds because just now the video is over. Just chat. I mean, what is the wrong in the DLT placement? Better next question.
Play it again.
Oh, okay.
See.
We thought time shortage, madam. That's why we are-
No, there is no shortage. It's very nice video.
Hmm.
Audience, please type your answers. It's okay even if it is a wrong answer. Don't worry.
That is why we are here to give you the answer.
Please try to answer.
We'll start with other questions, madam.
Yeah. I think you finish off these answers.
It's this answer. I do not know whether the people, anybody has given.
Yes, they have given. 3-4 people have given answers. Dr. Sagarika, read out the answers which are given. Subalipsa, just read out all the answers. Many answers have been given.
There are a lot of answers. So first answer, 90-degree rotation was not done. Then there's
Yes.
answer like clockwise rotation was not done. No 90-degree rotation. Most of the answers are that. No.
Correct.
One of
The
few of the
rotation
answers.
should have been done after the bronchial cuff is moved inside, but it is done after the tracheal cuff has passed through the vocal cords. That is the answer. Correct. If it is not done, correct.
Okay, so Subhalipsa, can you tell us the names of the people who have got it right? The correct answer for the video
Correct
MCQ?
answer. Prashant K. Desai and Dr. Charan and Dr. Nikhila. Anjana.
Congratulations to them. Okay. Yeah. Now go ahead to the next one.
Now we have 4 or 5 questions.
6 questions.
6 questions, madam.
So question
Done,
number
na?
1.
You're done with the questions? Okay.
Now we are starting the questions, madam.
Okay.
So question number 1, when a fiber optic bronchoscope view through the tracheal lumen shows broad flat carina with only small rim of blue cuff visible, unable to visualize the right main bronchus. So what is the most likely diagnosis? A, correct placement. B, bronchial and the tracheal and the bronchial cuffs are in the left bronchus and DLT is in the right bronchus. The D is cuff herniation.
C maybe. TLT.
Shall we go for the next question, madam?
So most of the answers are ma'am D, and Anjana was the first one to answer. And some answers are B also, ma'am.
B.
So correct answer is B. This is the fiber optic bronchoscopic view where there is a very broad flat carina with only a few rim of the blue cuff visualized into the bronchus and the right bronchus is not visualized.
Rohit has got it right then. He has answered B.
So question number 2, what is the best corrective step?
Of the same question.
Yes.
In continuation of the question number 1. Read them.
So A, rotate 90-degree anti-clockwise or advance 1 to 2 centimeter deep. Withdraw the DLT under fiber optic guidance until the tracheal lumen lies in the trachea or replace the DLT.
All of them are answering C. Withdraw
Yes.
under FOB guidance until tracheal lumen lies in the trachea.
Yes,
Okay,
correct
correct.
answer. Question number 3. In permanent tracheostomy patient, preferred lung isolation device if available, what are they? Standard double lumen tube, Narike double lumen intrabronchial tube, single lumen tube with bronchial blocker, or univent tube? Which is the correct?
All of them are answering B, ma'am. Rohit was the first one to answer.
Very good. Question number 4. The most important parameter to monitor doing prolonged high-frequency ventilation via FROA is saturation, EtCO2, peak airway pressure, or ABG, PaCO2.
Most of them are answering D. Only one of them have answered B, EtCO2. Most of them are
B and
answering
D both are correct. B or
PaCO2.
D. Yeah.
So question number 5. Why does clamping the pulmonary artery improves oxygenation during pneumonectomy? A. Improves lung complaints. B. Reduces shunt fraction. C. Improves ventilation. D. Enhances HPV.
People are answering both B and D equally, ma'am.
Yeah, correct, correct. So you find out who's the one who's both we can get.
Which of the following lung isolation devices does not depend mainly on single bronchial balloon cuff to maintain its position in the main bronchus? Ant, Cohen's, EZ blocker, or Inuvent tube?
This is not covered, but we just
Just
wanted
want
to
to
know. If the people don't answer, Madhuri madam, we should give a class on bronchial blockers next time.
Yeah, I think it is needed. You're right. You
Because
asked them one question, Aarti.
this is on blockers,
Which kind
madam.
of blocker have they used? Let them raise their hands.
Our students will raise, madam. They have
Your
seen
students
it.
will raise, but the remaining, I wonder whether they have seen at least.
Yes, yes, madam.
Ask
That
them
is
how
all.
many have seen an Arndt endobronchial blocker.
Yeah, how many have seen a blocker? And if you have
Huh.
seen the name that blocker in the chat, so that this will help us to keep a next class on bronchial blockers.
Yes, yes.
Difficult to cover everything in one class.
You
madam.
just type in the chat box yes or no. Don't worry. We will not ask you further questions on
Yes,
that.
just to
Even if
see
you
that
have
whether you have
used.
seen or not.
Yeah. See, nobody is answering, right?
And for this
There
question,
are. Oh, there is. Henjarappa sir has used all blockers.
Kidwai students.
Prashant. Yes, yes. No, no. Answers are coming. They have used Ant blocker, EZ blocker. Yes.
Very commonly used EZ blocker, madam.
Yes.
Common, very common than the DLTs.
answer.
Good.
Answer. So answer is EZ blocker. So this is a picture whereas the EZ blocker has two bronchial balloon cuff. One is for the right side, the other one is for the left side.
We have the video of that also, madam. But since
Can you show us? Can you show us if you have it now?
Yeah, I have it, madam. Just give us 2 minutes. We'll have to take it from the other
Sure,
slide.
sure. You take it and prepare.
Yeah, we will.
By that time, we will just find out if there are any more questions. I think Henjarappa sir can manage that part. So
Yes,
just find out, Dr. Sagarika.
Yes,
Dr.
ma'am.
Subhalit, any questions are there in the chat box?
Yeah, now you go to my.
There were only 2 questions, ma'am. Dr.
There were,
Shanmugha.
but there will be some more coming up now.
Yes, ma'am.
Yeah. Tell us what are the questions.
Dr. Shanmugha had asked about blood transfusion in cancer surgery. The first question.
Ask the full question. Blood transfusion is what is that?
Yeah, he just asked about blood transfusion in cancer surgery.
He has asked about blood transfusion
in cancer surgery.
Whether to do or not to do, is it?
Yeah, maybe.
So who can take this question?
Yes, ma'am, I'll take. We follow restrictive transfusion strategy. We'll keep a transfusion trigger of hemoglobin of 8 gram per deciliter for stable patients and 9 gram per deciliter for cardiac patients.
So you need to manage both the requirement along with the impact of blood transfusions, what the patients can have on the disease as well as on the treatment things. That is the reason, as rightly been pointed out by Rakshita, we use restrictive strategies in patients and we use other methods, starting from the preoperative period, correction of the anemia, the intraoperative, the corrections of the anemia, depending upon what type it is, whether it's iron deficiency, folic acid deficiency, or because of any tumor bleeding, because of it is there. Correction of all those in the intraoperative period, we use the advanced surgical techniques, minimally invasive surgical techniques like robotic surgeries, like the laparoscopic surgeries, then controlled hypotensions, antifibrinolytic therapies, then transfusions based upon the TEG and ROTEMs. See, these are all the things what we use. And in the postoperative period, we need to maintain a balance between the DVT prophylaxis and the bleeding. Okay. So we have many devices to maintain the DV, like graduated compression stoppings, pneumatic compression devices, molecular weight heparins, depending upon the bleeding. We need to maintain all this.
Yes. Yes. Going to go on to the next question.
So there's one more question from Muthu Kumar for you, sir. So he has asked, most of these patients have difficulty in securing IV lines after chemotherapy. So how do we get over those challenges?
Yes, because of frequent placements of cannulations and post chemotherapy and post radiation therapy, they'll be having difficult access. So for that, you can search in the other limbs where the patient has undergone, like where the cannulation was previously placed. You can search in the other limbs and using of ultrasonography. And the recent advance is that infrared vein finder and are going for PIC line on central line.
As we all know that most of these patients undergo repetitive procedures, okay, right from the diagnosis, like post chemotherapy, first cycle, second cycle, third cycle, and they go on for radiotherapy. So the most of the veins will have got thrombosis. So you need to search where you get a good vein, either with the help of, as rightly said by Rakshita, either with an infrared vein finder or with an ultrasound we can do. Or if there are no other options, if everything has been held up, you have to use either a PIC line or a central line to get over the things. Or most of the times, they would have got a chemo port inserted. Okay, we can use the chemo port also, but under strict aseptic precautions, we have to use them with a special needle which comes to use with the chemo port.
So the other question is, what are the indication of right-sided DLT?
Yes, right-sided DLT placement is difficult. So in cases of left pneumonectomy involving left bronchus surgeries, so we will prefer right DLT.
See, many times when they ask for right upper lobe isolation specifically, okay, when it was right upper lobe lesions or sometimes in the thoracic esophagectomies, okay, see esophagus involving the upper orbital, when they specifically ask along with the other indications we do for right.
Actually, we had shown in one of the slides, actually, it is missed out, I think, the indications for right-sided DLT. So, madam, we are ready with the video. Can we share?
Yeah, sure. Till that time, you be ready with the next questions, huh, Dr. Sagarika.
This is how we prepare EZ blocker, this video. Not coming. Right. This is the EZ blocker. Before placing the EZ blocker, check the cuff of each side. Each are color coded. One is blue and one is yellow. Then we load it over the tube, regular tube. You would have assessed the size of the tube requirement, and then we load it and keep it ready before intubation. It's a forgotten. Very tight. So we fix it, we load it, and then we tight and keep it ready. There's one more video which shows how the placement is. Again, we check the cuff of the tube. We deflate and check it. Stop. This is the placement of the bronchial blocker. We use CMAC to place the DLT. I mean, regular endobronchial tube is intubated. If you can see here. You have to be very sure. You should not put the tube more inside. It should be always 4 centimeters away from the carina. Then the placement becomes very easy with the EZ blocker. So always keep it around 19 only, before only, so that the EZ blocker placement becomes very easy and perfectly done in one go. If the tube is more inside, it goes off to one side. Then we can connect to the lateral side so that the oxygenation is not affected. We check the air entry bilaterally. So you have a time now because all ventilation is happening. Now you can place your. So now with the fiber optic, we are checking the DLT placement. Through the one lumen, we are putting the fiber optic. Now, if you can see through the screen of CMAC, it's very clearly you can make out. In this particular video, we had put the tube more inside. So the blocker had gone to one side. If I remember, this is done long back. And we'll pull the tube back. Pulling the tube back. So if you can see, the tube is pulled back. The ring has come out. Then I pull the bronchial. So now you can see that white color ring, the tube, that is the tube ring. I'm pulling it out because one side, the blocker has gone to one side. So I'm pulling it because you should keep 4 centimeters. If you put it goes to one side. Now I'm pulling it back. If you can make out the length is increased. Then I pull the blocker. Then the blocker is placed. Then the cuff is inflated and checked for the. Now, if you can see on the CMAC, you see it's snugly, nicely sitting at the carina, both sides. And you can even see the cuff inflated. The edge of the blue color cuff can be seen. Okay, let's go. Yes, madam, that was the video.
Very nice. Wonderful video.
Thank you, madam.
I don't know how many more videos are there in your box.
Yes.
We'll have to hijack your box. Oh, okay.
It's
good.
difficult to choose which one to project, which one not to project. Madam.
Yeah, especially because they come from first-hand experience, no? Your videos.
Yes,
Yeah.
madam.
Next question, Dr. Sagarika. Any more questions? Just check.
Yes, ma'am. Dr. Konda has asked, what is the main disadvantage of EZ blocker?
Main?
Disadvantage of EZ blocker.
You cannot isolate the complete lung. It's only lobar collapse you can do. Otherwise, it's difficult to do complete block. Placement is fine. Otherwise, it's only that you cannot use it always.
Okay. The next question, what's the role of DLT in prone position?
No, right now, we don't do it with prone position because it's difficult. If there is a malposition, it's difficult to take it out. So if they require prone position, most of the time now at present we are doing with the flexometallic tube and we give low tidal volumes, which was earlier done this method. And generally, lung cases are done in a semi-lateral position. Lateral position, we do give that. But prone position is usually used for esophagectomies. So it is a relative indication. They can still manage with the...
Okay. Dr. Konda has also asked about contraindication for right side DLT use.
We will show that slide again because we showed it. Maybe we can display it again.
Okay. There's another question.
Contraindication.
If intraoperatively surgeon complains of inadequate lung isolation, deflation, how do you go about it?
So most of the time, one is we wouldn't have used adequate size. But still, sometimes you would have used, but lung still, was my doubt when I joined Kidwai. The lung looks still inflated. So best is to use a suctioning. Suction after the suction and then deflate the lung or isolate the lung. I mean isolate. Do a proper suctioning. If you feel the lung is that time, it definitely deflates. Suctioning the side of the lung isolated.
Next question, role of ultrasound in placement of DLT.
So now ultrasound is the most upcoming thing in all areas. Ultrasound in airway is the most upcoming. Lung placement, lung isolation, it is a lot of things are coming up, but still we have not used lung isolation, ultrasound in lung isolation, because we need to know accurately how it is placed. So fiber optic is more accurate and you visualize, you have a camera. So that is still the gold standard. Ultrasound probably maybe in after a year classes, maybe we can have a topic on that.
But ma'am, in ultrasound, if you want to place in the lung, I think that's a challenging because to
Very
identify the
challenging.
structures on the USG, it's a
Sir,
very,
because
very
fiber optic,
difficult. You may not be knowing at which branch,
sir,
at
we will
which branch
not
you
know
are
at
placing the
what place
tube, but
is the
where you
tube
are.
also. Yes, sir. It is very, very challenging. I mean, I don't think it is possible at present. Fiber
Even in
optic is
the
being modified.
Even in the if you go to the trachea and upper airway, upper bronchus also, the main bronchus, what happens basically in the trachea, the tracheal rings, they deficient posteriorly, the three-dimensional dynamism, it always tracheal rings. You will still be able to know the otherwise what happens the three-dimensional, if you are using the three-dimensional USG or seven-dimensional USG, things are more precise, but I think even at this stage we are struggling to get the USG approved for every institution for use in anesthesia. That's a major challenge, and rather than the use of USG in our anesthesia practice.
Sir,
So
that is
that
what
thing
I
I
will
think
not
will
know
evolve
how
over the
accurate
time.
it is. But right now, fiber
With the
optic
7
is the
ultrasound,
gold
ma'am, I have seen with the radiologist. With the radiologist, what happened? Because they are the specialists in that. With the 7 ultrasound, he was able to delineate the segments of the lung. But for a normal person like us, we are not able to do that much of a higher study to get a course in that we will be able to isolate the segments or the division of the bronchus with the further bronchi where the division is actually occurring. So placement will become a little challenging with the ultrasound here.
more challenging, sir. May not be very tough because we have very accurate with the camera. Maybe that Viva site camera, which is a camera is in the
Fiber
tube.
optic is the best, ma'am. Fiber optic is the best till date.
Best. Gold standard, sir. Any other questions?
Yes, ma'am. Dr. Ashwa has asked about how often ABC needed for these patients if saturation maintaining in range of 90 to 92%.
Generally, we do one basic, in our experience, one basic ABG to know the patient status. The saturation up to 90 is always good if you're giving lung isolation. Below 90 only, you should get worried if we are SpO2. In between, you can get, when it drops up to below 90, you can do one ABG and check. And over that time, if the surgery is prolonging for longer duration, maybe after 2 or 3 hours, we can do one ABG as a protocol.
Dr. Sukanya has asked, what are the exact indications of bronchial blockers? What are the exact indications of bronchial blocker?
The one indication is difficult airway. When we cannot place DLT, bronchial blocker would be the best. We can place it along with a single lumen tube and we can keep it and we can use it. And if they want a smaller lobar collapse also, the only blocker can be used. The advantage of blocker is you use a single lumen tube. If I use a double lumen tube, I will have to take out the double lumen tube at the end of the surgery and put a single lumen tube, the regular conventional tube, to ventilate. Whereas in bronchial blockers, I will not. I will just take out the blocker and I will keep ventilate to the single lumen tube. So that is the indication. Difficult airway, only lobar collapse is required. And maybe in between the surgery, surgeon suddenly wants a lung isolation, we can pass through our conventional tube a bronchial blocker. I think Madhuri madam, I think next class should be on bronchial blocker. More doubts coming on bronchial blocker.
Yeah, true.
Sometimes preventing the soiling also, extravasation of the blood on the other side also.
Sir, that's
You
absolute indication, sir. Yes, sir.
Yeah. I think, Dr. Rajiv
Yes.
sir, we will do one thing. In the next class, we will see who is asking with what designation. So we will form a special prize for the consultants and a special prize for the PGs who can ask the best relevant question related to the class. I think we should start that also now.
Definitely, it will improve. It will improve
Yeah.
the discussion also.
Because we don't know who is asking at what level, and so that we will be able to know that even at the PG level, third year, second year, first year, or a consultant level you are asking, that's the best way to go forward. So I think you should institute that one also. That's a little advice from my side. That's the best way.
Absolutely, absolutely.
The last question, how do you achieve one lung ventilation in pediatric age group?
You get a double lumen tube of a smaller size.
And
Similarly.
what is the smallest size available for pediatrics in our country? You must have seen that also.
28, sir. 28.
28?
Mm.
Okay. And ma'am, in Kidwai, are you using that for a single time or you are using it for other also purposes?
Double lumen tubes, sir. Most of the time we are using single times.
Single
And
time.
sometimes unofficially we keep it ready with sterilized, and then we use it if it. Most of now we have ample supply, sir.
So suppose, ma'am, the tube cuff goes during perioperatively or the
Many
surgeon
times happens, sir. While intubating only it goes off many times.
So I
That is
think
one more complaint.
you must be keeping the reserved one, those which have been used earlier. You
Sir,
must be
usually
storing
when
that
we
one.
want to isolate the lung, we keep 3-4 tubes ready, sir. Not one, two, sir. Many tubes we keep ready, sir. Of the same size also, of the different size also. 4-5 boxes we keep ready, sir. One size bigger, smaller, of the same size, 2 sets we keep, sir.
It's a rich institute. Rich institute. Kidwai is a rich institute.
So because suddenly cuff goes off, we're helpless. I'm working here from past 25 years. I've seen what all possible types of complications when I was learning DLTs.
Yeah, so you are in a stage where you can define and redefine the oncoanesthesia in the setups, especially in our developing country setups. So that is, I think, another chapter you can write on that.
Thank you, sir.
Today we can see Dr. Indrani also coming. Very enthusiastic, madam. Madam is there today. Madam, you can also ask. I think she has to unmute. Dr. Rajiv, you have to unmute, or you can enable the disable that waiting room.
She's unmuted.
Very nice lecture. I really enjoyed it. I mean, it was completely all practical, tips and plenty of videos. So that made it even more interesting.
Thank you, madam. Thank you.
Madhuri madam is raising hand. Please,
Yeah.
madam.
Yeah. Now, one question to you all that or so much of literature and so much of things are coming on ERAS in oncoanesthesia, oncosurgery. So what are you people practically following over there? We would like
Madam,
to know, like rehabilitation and all you have already told.
Madam,
Like,
prehabilitation,
are you all following
carbohydrate
that?
loading. Even one of my student is doing a dissertation combined to assess the ultrasound to assess the residual gastric volume when we give this preloading 2 hours before the surgery, whether there is any difference in the residual gastric volume when we give the carbohydrates 2 hours prior and for overnight fasting.
Okay.
And many things, madam. We have been practicing like colonic surgeries. We practice the ERAS protocol, like building up the nutrition and seeing the long-term outcomes, carbohydrate loading, counseling and their effects.
And
Many
about
things are
that,
being.
Are
not
you
giving
giving
the
enema in these patients? The
No,
colonic
madam. No,
cancers?
no. Only even there is complete obstruction, because most of the patients, if they have obstruction, they'll go for diversion colostomy or ileostomy, madam. Yeah, most of these cases.
Okay. So that means you all are practicing some of the steps of the protocols
Yes,
you are
madam. Yes, madam.
trying
Yes,
to
madam.
implement,
Even
right?
Yes,
sometimes,
madam.
some cases
Yes.
put oral nasogastric tube. I mean, orogastric tube.
Okay.
And
They do
early
very better.
mobilization, early removal of the drains, early removal of Foley's catheter,
Early
and we are
ambulation.
trying to institute the enteral feeding as early as possible. All these are being practiced, madam.
Multimodal analgesia.
Yes,
and all
madam.
that.
Yes, madam. Yes, madam.
And,
Acha, and
yeah,
one more question I had for
and
you
also
people.
because cancer cachexia is a very important problem
Yes,
for
madam.
you.
Yes,
So the
madam. Yes, madam.
frailty and the cachexia
Yes,
is
madam.
a very important indicator of the outcomes.
Yes, madam. Yes, madam.
Have you
Definitely.
studied the outcomes in these cachectic patients?
Madam, definitely nutrition plays a role, not only with the immediate outcomes such
No.
as
I'm
wound
just
healing
asking,
or
have
the
you
anastomotic
studied?
dehiscence. Yeah,
Yeah,
the surgical counterparts, madam. Yeah, they have been publishing papers. Okay,
yeah.
many of them, especially in colonic cancers, to see how is the wound dehiscence or the wound healing, long-term follow-up of the patients. They have been doing, madam.
The albumin levels are also
Yes,
low.
madam. Yes,
Proteins
madam.
are
Yes,
low.
serum
Yes,
albumin levels, everything there.
yes, right.
Dr. Anjirappa, one very simple question from my side.
Yes, sir. Please, sir.
How frequent do you people do the post-op rounds in such cases?
Sir, we keep the patients in our post.
No. I'm sorry. After shifting to the wards or to the HDU, so how many times you really do the post-op round? Because these patients, they don't just have that typical recovery like other patients, no?
Sir, one thing is, as a government institute, we are not that much have faculties to go for actual post-op rounds in the wards. But as long as the patient is in our surgical ICU or in HDUs, we take care of them. Only once they are stable, the patients are shifted to the wards, and our residents will address, because in the hospital, our residents stay 24/7. Anytime, any call, be it be for an IV line, be it be for a Riles tube, be it be for hemodynamic, any chances are there. Our residents are always there and they do it, sir. And
That
the
is
on-duty consultants will go, sir, in the
that is when
wards.
Most
the
of the time,
complication
the
comes.
call will come for pain.
Yes, sir. Pain.
Most of the time, the call will
Yes, sir.
be for pain only. In spite of
Madam,
epidural, some of them get pain.
madam, two things what we encounter is, one is IV lines. Okay. Difficult IV lines is the one which we get most of the calls for.
Yes, absolutely. I know.
Yes,
I know
madam.
that. Yeah.
Yeah.
And the second one is pain. Because
Pain. Yes,
after
madam. Yeah.
24 hours or 48 hours, the epidural is out, and the
Yes.
patient is wincing with pain on the third postoperative day.
Yes, madam. We
That is
take
the
care with
problem.
the, yes, madam. Yeah.
So we get calls for that. I know.
Yes.
And before Dr. Madhuri, just one question more, extension of that part only. Do you keep a data record of the readmission of post-op patient when they go to the ward, coming back to the OT for re-exploration for any complication? Do you keep that
Yes, sir.
record?
Yes, sir. Yes, sir. Yes, sir. We
And
keep,
what is the exact rate?
like our madam is very particular about that. She has maintained like which case comes for re-explorations, and if the case is coming, how many times it is coming, and what was the reason for it, and what was the outcome of it. Okay, whether it was any problem in the post-operative period, whether it was surgical complication or because of anesthetist or what it was. We usually have a data, sir, for that.
Publish it.
Yeah,
That's a
definitely,
simple
sir.
thing I can
Definitely.
say.
Statistics, sir.
Publish
Sir,
it.
not
Publish the
only
audit
for
report.
publishing, for our own this thing also, we keep some data, sir.
Sir, yes, sir.
Audit
Statistics is
it.
done
Dr.
every 6 months. I make all the statistics done and keep it with me, sir.
Dr. Madhuri.
Yeah, and this TEG and ROTEM, no? You all are using for which kind of cases?
We don't have, madam. We don't have.
Madam,
We are yet to.
we are yet to say right now, as Bajwa sir said, we are rich institute. We are not that rich to have these on hand, madam.
Okay.
It is yet. I mean, that is in the list, madam. Once we
Okay,
get,
that is in your hit list. Huh? Okay, right.
So I think it's a time on the secretary, sir.
Yes,
On
Sure.
your,
sir.
on your behalf and president and IS and national, shall we go with the felicitation
Certificate.
ceremony?
Sir,
Yeah.
please, sir, please.
After that, the secretary should inform about the cultural program.
Yeah, definitely.
He will be. So,
Madam is very particular about that.
so it's a privilege to at least present the certificate of appreciation on behalf of the president, secretary, and the governing council members. So, Aarti madam, you did a wonderful job in getting this one done, and this was long due, and
Long due.
ultimately it happened, and we are really thankful for you being the leader of this team.
Thank
So
you,
we
sir.
are.
Thank you.
It's a privilege to honor you on the behalf of ISN National, ma'am.
Thank you, sir. Thank you.
And the other person is Dr. Hanjirappa, who has outgrowing his stature as a secretary of Karnataka now, and more of a clinical side also. So the other side of the Hanjirappa sir is now being shown to the world that is one of the clinical anesthesiologist, and he will be making a mark in the publication as he had promised. He will be publishing the audited report of Kidwai, which will be required in the IJ also. So thank you, Dr. Hanjirappa, for being the second leader of this class.
Thank you, sir. Thank you.
And Sagarika, yourself, I think it was very impressive the way you handled the initial stages, yourself and Shubha Lipsha. Both of you did a wonderful job as a screen coordinator.
sir.
Shubha Lipsha, she was with me last evening, and confidence is oozing in both of you. So you are going to make a good faculty in the coming days.
Thank you.
Thank you so much, sir.
And Rakshita and you and Nasreen, you were both impressive. Your presentation was really good. The way, the confidence, because this was something new. Just the teacher and the presenter sitting side by side in the, I think the first time happening in the last 6, 7 years of the class, and asking the direct question to them on the face, and they are answering well, just like not like a copied thing, but in a very confident manner. So you are doing well. You have done well, and we are really proud of you. So you
Thank
will
you,
be
sir.
doing good in your final examination also. Thank you
Thank you,
both,
sir.
Rakshita and Nasreen.
Just to
So
break the monotony, we did this, sir.
yeah,
Otherwise,
that's all the good concept today. But how do you
to
make
break
that
the
one PG
monotony,
sit
we
with each
discussed.
other? Just like the final examination happening today.
Yes, sir. Yes, sir.
Yes, sir.
Actually,
Rajiv sir.
actually sitting together, it gives more confidence to the students. That is, such a teacher of such a high magnitude is sitting with them and asking the questions. This gives them very great confidence. So that is how they were answering very well. Though the preparation was good, yes, I can understand, but sitting with them is something more, making them more confident. So
So
it was.
I think they have exposed their PG to the externals now, so they can recognize tomorrow they're going to take exams. So this picture will be there that they are already given one exam. So you give the internal assessment already to them.
Yes. So it was very
So,
excellent lecture and discussions, and I think it was very practical. The way they explained, Dr. Henjerpa explained about the oncoanesthesia and the discipline about it, how they can manage the patient very operatively. What is the importance of ERAS and everything? It was very well explained. Similarly, Dr. Arthi, it was wonderful presentation on one lung ventilation. Actually, it was like sitting in a class, and it was not looking like listening to something else, but very practical. And what are the complications and how the things can proceed in a different way and how to rectify them. So that was very important. So thank you everyone for this class, and best wishes to all of you. I
Thank you,
congratulate
sir.
all
Thank
of
you.
them.
Thank you, sir.
Thank
Thank you.
And thank you to all the people,
Dr.
especially.
Bajwa, Dr. Raji, he has to announce the cultural program. He's not
Yeah.
doing it.
Yeah.
Arre,
So one very
Secretary
important
Saab.
information regarding the cultural program. On the occasion of Mahashivratri and Shivaji. What is that one?
Jayanti.
Shivaji
I've
Jayanti.
written I've sent it to you.
Yeah, yeah. So it is on 19th of February, and the time is, I suppose, 6:30.
Yes.
Yeah, 6:30 to 7:30 on the Zoom platform. I will be sharing the link very
That is
soon.
tomorrow,
No,
19th,
no, on
19th,
Thursday.
19th,
Can I say that then?
Thursday,
19th, yeah, Thursday.
19th. Okay.
Yeah. So you can see Dr. Indrani dancing in that program. I don't want to tell the things about it. You just come and see how
See the
well
live
they have performed.
performance.
They have performed. Yes, yes, yes.
They see the well-talented GC.
Yes.
So I just want to say that Maharashtra ISA is putting up a complete bouquet of song and dance celebrating Shivaratri, celebrating the great Raja Shivaji, and also going with the celebrations of the month of Ramadan. So these are the three festivals in February. So Maharashtra ISA is taking that privilege to present this bouquet of entertainment to all of you. So I want all of you to please join and motivate us to be to to have more and more of this kind of a program.
Sure, we will be there,
So
ma'am.
so we warmly welcome all of you, and I'm sure you all will have a memorable program on that day.
And I think, if you will attend that, it will, persuade you also to have such a nice cultural program. Because, in anesthesia, very many people, they have different hobbies, and singing, dancing, everything is there. So even Karnataka can have a special program of this cultural program.
No,
Any
every
of the
state
occasion.
is assigned a particular month.
Yeah, yeah.
So that is why this month is assigned to Maharashtra and Orissa. So being a Shivaji Jayanti, Maharashtra is very proud of Raja Shivaji. So the valorous Raja Shivaji. So then, so that is why Maharashtra will present in February. Every state is given a particular month. So
Madam, ma'am,
culture of each and every state will come out
Yes.
every month.
ma'am,
That is the idea behind
Dr.
it.
Rajiv is from Delhi, capital of India. He will take all the state in Delhi only, and every month he will be putting up in Delhi. So don't give him that liberty that you can assign. It's I think we will be doing that in a different manner. So every month will go to Dr. Rajiv Gupta only from
No,
the
no, that will
capital
be
of India.
that would be annual. Annual, when
Yeah.
we will combine all the people from all the states. That would be annual.
Okay. I think we should also thank our special people like Dr. Madhuri and Dr. Raki who are doing good work in preparing these classes. So they are doing all the jobs. She's doing editing job also, the professor job also, and the classes also. So thank to them also to Raki. Raki is doing a wonderful job now. She has become veteran now in this classroom teachings. So Raki,
Yes,
keep up the good work.
absolutely.
It's very important. And to secretary also who has come all the way from the hospital, that he always take time to come from the right time from the hospital to sit in the class in spite of the busy schedule. So he is living up to all the what you call the secretary's workbook he has adopted properly now. So
See,
that's
it-
I think what you call the charm of these classes, sitting all the through. And I
yes.
know what he must be facing at home. Well, now leave the class with how many classes you want to do, how many webinars you want to do. But that's how the thing goes on. So you have adopted to that new
Yeah.
post now.
But never that sincere in
But
the regular
Ranjirappa, don't
classes
look
when we
like
are in
that. You will
PG.
also be doing certain things in the future.
Sir, we have our state webinar scheduled for Friday, sir. We are
Okay.
That's
conducting on T1
that's okay.
TCI, sir.
But you will be having more responsibility.
Yes, sir.
More
Yes, sir.
responsibility is going to come very soon.
Yes, yes.
Yes.
Our support is always there with him, sir.
Yeah.
Thank you.
Thank you so much, ma'am.
Thank you, sir.
Not with him, madam. Your sport should be with everyone. People like us
Yes,
also.
sir. Yes, sir. Yes,
We
sir.
are doing national work. Rajiv, myself, Dr. Madhuri, Dr. Indrani.
Yes, sir. Yes, sir. Yes, sir.
So it
Thank you
should be
so
with
much for
everyone.
giving us the opportunity, sir.
It's a wonderful class, ma'am. It will be available on the ISA NHQ at YouTube after the
Thank
class is over. So you can always watch this class. Yeah. Rajiv sir,
So thank you so much.
time to say
Thank you
goodbye.
so much,
And
everyone. Good night and long live ISA.
Long live
Long live
IS.
ISA.
long live ISA.